when I look at these risk groups, I tend to look at good risk patients as patients that I think are going to live a long time, and that's based on their risk group stratification, but it's also their tumor burden. And one of the things we're beginning to do and recognize is that there's also a role for active surveillance in many of these good risk, low volume patients. With the intermediate risk, this is probably our biggest risk group overall. It's probably over 60% of the entire population. So it's where a lot of our patients fall, and it's where I really like to be proactive, because these are patients where it's a little bit unpredictable how they're going to do. Some of them do really well, some of them not so well. But in general, I'm going to want to treat those patients, and again, treat those patients probably with an IO-based regimen. And then for patients with poor risk disease, it really depends on what I think patients can tolerate. For many of these patients, they may need immediate palliation, and drugs like cabozantinib can really result in very quick responses, which can be helpful. And then we can transition to other agents further on. Some of these patients may not be good candidates for that, and we'll think about IO therapy. Some of these patients, unfortunately, really just need palliation and good supportive care, because the disease can be overwhelming depending on other comorbidities and whatnot. So it's a challenging spectrum. I don't think there's any one answer. We do have to individualize, and I do look at these risk groups, and I don't tend to lump them. I tend to separate them, and also think about tumor burden and symptoms in the context of them.